It's so impressive to be here. Hello to everyone. When Guy was proposing this roundtable, I was thinking of the Le Point magazine's ranking of hospitals. But this year we won't have this hospital ranking, and because the the CNIL has been asked to have its opinion, and the CESREES is the Scientific Committee Ethics for Health Research Studies and Evaluation, CESREES. And so the evaluation negative from CESREES, the Council of the State gave its conclusion in last June. It was very interesting conclusions in which it said that there were some reservations made concerning the criteria and also the notoriety and the function and proportion of patients that came from a different service outside of the hospital. And so the government was looking at how many kilometers between the hospital and homes, and this is okay because based on our information from the Le Point, they did not have this included in the ranking. So the Council of the State concluded that this ranking has different information that is not does not interest of the public, and so the action of those concerned was that those who have access to this information was that, and this is the topic of this, we'll be talking about this. Is this in public interest? Not everyone. Can you tell us, Madame, what is your actually objects of your task? How does everything function in CESREES? So we'll start with Bernard Nordlinger. Yes. So we have the insurance reimbursement, and that's very important. And we have certain conditions when we use the data from our patients. There are rules, and they have to really be useful in the interest of public. We have to increase knowledge. We have to increase the health system, etc. Now, all of the requests come from CESREES, says Nordlinger. He gives an opinion concerning the relevance of the scientific ethical use of this information, and then it's the CNIL which actually gives the authorization or not. And this is for this. We have different organizations also involved, and so they can inform directly patients. So it's important that patients have personalized information. And the CESREES is composed of 20 members, which are appointed by this decree published in 2020, which in fact are representatives of these major research institutions, the Council of State, Minister of Health and Research, and 2 representatives of users and patients. And so we also have 40 different experts to cover the different medical areas. And each file is evaluated by 2 spokespersons, a clinician, a biologist concerning the technical aspects, and also epidemiologist, because this health system is not very easy. We can't always find all the information we need, so we need specialists. So CESREES' role, and this is very important, is not just to simply be the police of the data in italics, but it's also to the CESREES. We have the use of specialists, and to talk about the figures. We, in 3 years, we had 2,000 different opinions out of some 900 different documentations. We had favorable opinions for the first round was less than 60%, and the proportion of favorable opinion after reviewing was 85%. And so this is a committee which really wants to be positive, to really seeks to use well this health data. Now, we'd like to know about the demands and your responses. So it's a good question because we have the rules, and the CESREES response in 1 month. We, in August, in fact, we had 2 in September, so we had a lot of work for the different rapporteurs, spokespersons, and so we have some 3 to 10 hours of work behind this. And so you have some 60 per month. So we reply in 1 month, and then it can be renewed in 1 month. And so for CNIL, and also making the data available. We'll talk about that later. So we prepared this roundtable, and you were saying that the reluctance is not from us. It comes from all the different people in health. You were talking about in the Paris organization, the APHP. And how can you really, what can we do about having access to this data? Yes, well, the CESREES is an independent body. And so we have this national platform, data hub, which offers a single window to actually have access to this request. And then we have the different warehouse data in the different teaching universities in the other areas and entities. And this data is organized in these platforms and ranked. And all the question is, how can we, what is the best way of having access to the data? And this is being organized. There is a problem in France currently, which is each one has ownership. So they have the ownership of the data. So they say, I worked hard on my data. I want to make sure that I can have this data being used correctly. It's not my data. It's data for everyone because it comes from Social Security sources. These platforms come from financial sources from the government. And then we have the European regulations, which requires sharing according to specific rules. So this is one of the problems, one of the issues. And also making the data available is another issue. And that's also something that has to be raised. Now, you have a very original initiative that you've done. You have constructed this statistical tool and medical economic one based on your own data. And also, this has enabled you to have the different diabetes patients for certain territories. Now, this initiative and this access to the data, and how can it be beneficial to the patients and also the professionals? Yeah, thank you very much. Yes, I think the basis of all of this is this notion that we've been defending now for some time, which is in the responsibility for the population. In a given territory, all the different actors in the health area are responsible. And first of all, it's important to know what are the health needs of the population aimed at. And so what we've constructed with the different scientific communities is based on the nationwide data. We have a stratification, which is clinical and medical economic of this given population. So what does this? So what is the person at risk? Who be the possibility of developing diabetes? What is their level of illness? And what does this correspond into the demands for healthcare? What do we need to do so that each one of these persons can to avoid that they would actually have diabetes? How can we prevent this? So this will give us an idea of the health needs in a given territory, and not just really. The idea is just simply, just a simple one. But the stratification is really to aim at a given territory to give a local idea of there's, for example, 800 person in this given level of diabetes, and so you have 4,000 at risk of coming up with diabetes. So this is in use. This information is used in the territory, and so what do we do well? What do we do not do well? What are the needs of each one? So what do we do too many examinations? Are we following well? And we are able to develop locally the different health programs, says Antoine Malone. And we can do this with the patients, and this is what we're doing. Our population, we see what should we do, how should we organize to target this population and help them, each professional one. Once we know the situation, each patient, we know where they're at, and what should we do for this given person, and a personalized approach. And so you have been experimenting in this Article 51. You've identified 5 specific territories in which you're proposing each professional health work to have a PDF of file access direct. And what are the results of this concerning the health, those that have been targeted, these patients targeted? What are your concrete results? The first one is, this is all in theory, but how can this be done practically? So this is why we said, we have 5 territories. We would, as pioneers, will be developing, testing, and re-rolling out the model. We'll be using all the same stratification criteria, the same territory pyramidal approach, and each territory would have their own health program because they're not unified and not uniform. So we have different profiles we look at, how we can organize. And so what does this do? In these 5 territories, we have these standardized approaches, but really based on a given territory. Each of these 5 territories are in this Article 51, very territorialized programs, but they share the same methodology and the same standards, etc. So this enables us to have a model which adapts for each territory. How many people, how many patients succeeded having the screenings? Today, we have some, the rollout, let's say, okay, started in January. Just after COVID 2022, we have 800 professionals working with this, and so we have 75 partners. We're developing citizen ambassadors, so we can really find people that are very far away from the health centers. So we have different primary prevention, 13 million that have been discussed, and awareness concerning the risk. So we have 3 million that are followed up in these 5 territories. So today we see that professionals can use this tool. It's very easy to classify a person in a given level, stratified level, etc. So it's working. Yes, we can evaluate the proportion of going recourse to the emergencies of those who have diabetes, which is 20%, the proportion of the different outpatient services. We can use the hospital at the right time for the right patients, and the proportion in the outpatient has increased by 20%, and the longer stays in the hospital we have been reduced by 1/3, because we know people are very well followed in these territories. So this information is very beneficial to the professionals, but also to the users and to the health system and globally. So, hello. Now, in France, we're very fascinated. When we talk about money, it's like money doesn't exist. It's like health is free, and the industrialists are always suspect when they propose to be a partner, because when they do clinical essays, etc. How do you really handle this? Well, says Madame la Hoste, we hear them. We don't know if the French are louder than others, but we do have some 2% of really refusal of these health space. There was a study this year. The French people really think it's very important to share their health data, to have better prevention, to have research purposes. And then you have the industrial and private, and I'll be talking about that. But it's legitimate, I would say. Myself, it's legitimate to say, what are we going to do with this data? We need to educate and to explain that scientific data for the industrialist area is something that we don't hold. It's anonymous. It's handled by a third party. So we have a methodology that we need to explain, we need to reassure. And above all, we need to have an interest, of course, to have these studies. That's the first point. And also, we have really concrete examples that we have to shed light on so that we can convince the public interest of the share. How do we do it? What is the right way? And it should be anonymous. In the projects we've done in my lab, there was one a few years ago where we had special treatment of different products, and when they were marketed, often we didn't have the data for these given ones. I was thinking for a pregnant woman, for example, this was a very well-tolerated product based on the former therapeutics, but with the rapid development, we can't do everything at the same time. But thanks to this retrospective study with a partnership with a cohort of the research study, INRS, so we could look at the data from pregnant women. We just added different studies, pharmacological ones, studies, and this was enough to evaluate by the ESM to market and authorize this product to be used by pregnant women. This is the kind of element of information that enables us to have a better use and extend this product product to a larger population group, like pregnant women in this case. How can we communicate to women? We need to have this information to convince patients. So yes, education, you have to explain, you have to tell them the individual and collective interest in sharing this data. It's not just my data. Okay, the researcher says the data is their own data, but we need to share this data. You've explained, and that's why we prepared this roundtable. You have the industrial side, and so there are different issues. What you've told me is this time period is connected to the insurance system. How can you and others, how can you reduce this time period? You were talking about this gold mine. Well, it really is a unique richness. We all share data in the hospitals. We have cohort, we have registers in rare diseases that are well structured. We have the different databases, nationwide clinical ones. If I look at other European countries, there's no country that has this national database of high quality. And there is a challenge in the industrial perspective of competitiveness compared with other countries, because these data, health data, they take place in UK. They can also have access everywhere, Israel, Spain. But it's better for us to do this in France, and this is our ambition. I think this can rally everyone, is to give us how can we make France a high-quality research area? How can we really shed light on the high quality of our hospital and healthcare system? This is an ambition that we need to all rally around. There are time periods, yes, which is really having a negative impact on the competitiveness of France. If I compare it to UK or the Spain, there are some time periods for the different studies, but there are other administrative time issues, and also the freshness of the data can be questioned. If I have sometimes it takes 1 year and so you get old data. But it's, in fact, if I compare the UK, I get this data in 3 months. Once we've had the evaluation, I get the data right away, and they're updated every month. Yes, it's very complicated. I don't have this solution. It's easy to talk about the needs of industrials who can participate, because it's really good. If we create all these different data warehouses, but if we don't use them because we don't have the right time periods, then it's too bad. So if we can structure, and us as industrials, if we invest in these different research projects in France, is where all together we will have a positive ecosystem. Do you have the feeling that things are improving in France, or they're not improving? This is a real debate. So no, this is 4 years now that I'm in my role. 4 years I've been talking about this. We don't see much progress. We talk each year about this. Go ahead. So each year we talk about this in CHAM, but it would be good if we improve, we say. Yes, I just wanted to add something concerning this problem, which is making data available. It's a real problem, and it is a very unfortunate problem. With this database, we have something unique, and we don't exploit it as it should be for many different reasons. And if the CNAM cannot make it available, we have a health platform which is to have a copy of all this database to make it available. And for different reasons you've all heard about, also from the different sovereignty questions, says Dr. Nordlinger. So things are not working. So it's the CNAM which really cannot follow it. So in the different dossiers that we receive, they're not all going to be getting Nobel Prizes. But what should be the priorities? That's another subject. Maybe next year we'll hear about that. Okay, so you are the deputy at the National Assembly. In 2000, you had a bill to improve the health, and so now we still says we're addressing. So Mr. GRELIER, from the member of French National Assembly, how can we make a real health prevention policy in France. Well, it really is altruism for a member of parliament to say everything is politics. That reassures them. No, it's good for their ego to say that. It gives the elected officials that they can handle all subjects. But if there's a subject which should be a major political priority, is the health data. It's a major political subject because, as we've said, we cannot talk about health data if we don't put on the table at one point we talk about the risks and the consequences in terms of national sovereignty and the exploitation of our health data. In the spring 2020, when we're in the middle of the health crisis, we all were condemned to be looking at BFM all day long. We discovered with really amazement that they would be the Palantir, the American group that would be exploiting this data. Now, is this a good data? So we were saying this American society, which was actually supported by the CIA, and we should mention that. Yes, we have that first problem. And also, the health data is politically related because this enables the politicians in the health area, for those who are voting and those who really implement this, they can evaluate what is done. We have this evaluation within the system. We saw this. We have the discourse of Guy Valenciennes, this model that we spoke about to talk about the relevance, the efficiency, efficacy of our health policy. And then you have the health system, which is the one interested members of parliament like myself, and that should enable us when there's a unique moment at the National Assembly. We talk about health and the different bill for Social Security, which is a unique bill. I deplore this bill. We have to have health data, which enables us to do a very fair and right evaluation. So we have data, and I address and applaud Michael, Jean-Marc that are behind me. We get very relevant data, which enables the elected officials to make decisions. And also, the Cour des Comptes also produces reports, and no one can really question the relevance. But also, it happens sometimes too late. But then to the Cour des Comptes that examines the Social Security, which I'm a member of this committee, we produce reports. But once again, there is a gap in time, so we cannot adapt policies in the time period necessary. I'm going to tell you a little story. In 2020, I had an evaluation report concerning the different agencies with Agnès Firmin de Bordeaux. And you see, this really benefited more Agnès than myself. So I wanted to add that. But in any case, when we had this report, we had a video conference. It was in the middle of the crisis, COVID crisis, and this was also with all the French and French overseas territories were involved. And Martinique was saying, "Mr. Deputy, I have a service to ask you. Can you pass a message to the French health?" So I had the DJ saying, "You, high official of the health, you're addressing a member of parliament to address a message to the Ministry of Health." Well, she said, "Well, no, they don't listen to me at the Ministry of Health. Can you just tell them, the Ministry of Health, to do these special posters, campaigns, radio campaigns in November and December concerning the anti-flu syndrome?" It does not work because it's summer in Martinique. So if you measure the difficulty that we have to have a right evaluation of our action and our public policies. So from this point of view, data is important. It's strategic as well, because we cannot really have access anyway, and just under any condition to have access to the data. When we had different dates, in 24 July in 2019, I directed the attention of the Minister of Health, Agnès, and saying we need to look at the definition of the public interest. We have data hubs, we have the CNIL, we have the CESREES, etc. I consider, and this is a legal deformation perhaps on my part, but the Parliament makes the law, and then the justice is one that implements it. And so you have the Council of the State and the Constitutional and the Parliament. None of them had really defined what is the public interest in the health area. So when we have a data health hub, so what I'm really concerned, which you have this, is it when you have for example, you have an independent ministerial authority like the CNIL, which says what is the right for such an important major challenge, which is access to data. The public public access and territory is very important. So we should elaborate a possibility of following the screening of the COVID during the COVID period, the pandemic. So what is the information the same if we're a patient or a health professional, or if we're a private actor like Social Security? And so to define the health interest, how do you define what is the public interest in the health area? I would also say also for the major public, because so really I want to know about can you answer very, very quickly in 2 words? Yes, I will have a bill concerning the programming of health for a 5-year period, because very, very ambitious for 5 years. Well, I'm always very ambitious concerning health, and so I haven't had all the effects I want to have, but I still believe we'll make progress. So the public interest is exploitation of personal data for a general interest to improve the health of French people. That is a simple definition. It can tomorrow be the legal basis of which the GRELIER and the Data Hub will be creating their own case studies, jurisprudence, and we will have a legal database. Today, we don't have that. This is major. If you had asked me how at the beginning, maybe you could ask me in the introduction how I would handle this. And I don't have the COVID, but I feel a little bit feverish. When I say I feel this, I'm going to give you some health data. We also, behind all this health data, is also connected to political resources where you need education. You need, as you were saying, Madame, you have to, when we will have the social media, when we talk about our health situation, when I query Google, if I'm feverish, shall I take Doliprane or aspirin, then I'm giving health data to people behind that. They're going to exploit this data. And all this today requires that we have to have more responsibility put on the shoulders of our citizens. So you go the public interest to general interest. General interest, I hear to improve the health of French people. Would you agree with that definition? Or how do you define the public interest, general interest, which is at the heart? We want to inform and share people. Who would like to answer? Well, I'm a surgeon, so I really like practical things. I'm not too much in semantics. Well, you really complete each other, complementary. I live, well, so in CESREES, so I have that complementary aspect also in my work. Go ahead. So we, in fact, we already, with the INDS, we also defined a lot of public interest. So to go back into this subject, so public interest is really what can benefit the health of French people, how we can improve their knowledge, how we can improve the health system. And it does not exclude that the requester, the one who has a project, is private. So in other words, a pharmaceutical request to improve a drug, it is not contrary to public interest. In fact, so the private sector should not be excluded. Yes, I think public interest is really the finality of the use of data should be to improve health and also the well-being of patients. And also we need to have a certain form of human guarantee. The patient themselves have to be capable of saying, I do not desire, or I want, or I desire, I don't want to have all this data shared. So you have to have that balance. But first of all, it's important to take a pragmatic approach, and maybe also I would like to say we spoke a lot of the major databases, which is really the heart of the model. This is the gold mine that we have. But in really what is really important and what happens at the level of the patients and professionals. And there we see that the passage, in fact, we see this as a model. We have these national databases, and Professor, you would agree, we have these pyramids, we have figures that are anonymous, and and they are, however, lately published. So for a hospital, then this could be an issue. So I want to know how many are in level, what is the level of diabetes, and so we already have this data. These are patients that are already in the different tools of professionals. So if we have, how can we use this data and practically in a daily basis, how we can exploit it? And here we get to a level where we see that we can go even much further. What will be very much of interest, the doctor, the nurse, etc., they say, I have so many that are in each different level. If I have a question to be raised, I know I call the hospital. And I think that is really the good next step. We need to work in a more operational aspect in the use of data. I really like what I just heard. 80% of the performance of operations is where we really have, I want to talk about the operational use of data relate to a real context. I think everything has been said concerning the better knowledge, development, the good use, master the volume. We've heard about this, and how is it used for which patient can benefit better. So all this analysis of health data, which helps for prevention when we do a major program of prevention with a vaccination. How can that help with even all the different chain of the health issue, even for the economy of the health issue? How can that have a good impact? It's not incompatible with a private lab, which needs this data as well. Nothing is incompatible. We have to be very vigilant, though. You have data which are very personal to the French, and these are contained in our different legal files, and sometimes they also come up with general interest. If I have a public authority function in the future, and if I have a police record, then it would be very important to know, because otherwise I can take up a public office or not. So the law has fixed the conditions in which we have access or not to this data, the health data. Okay. In fact, in my level, in my eyes, is it the same? We cannot access to the data of the French under any condition. It seems that once again, it's a law to at one time to stipulate what is a legal framework in which all of the different actors that have this responsibility in the health area, for example, the organization you preside and the other organizations, ACNI and others, how can they give them this room for maneuver? We don't have this yet. It's necessary to have that. You were saying yourself that the French already, they also have a voice to say it. So public interest, and you have a question, and you have the response. You mentioned this hospital ranking of Le Point magazine, and it's very of public interest to know which hospital they should use. The way of responding is not to have disinformation. And I wanted to say, based on what you said, I was thinking of a comment from one of our colleagues. I organized a colloque with colleagues from MIT and Harvard, and Leonard Cohen, who is at the chair of Harvard, was saying it's really surprising that people are more careful about the data concerning their body and than their brain, and they'll say anything about their brain. And can you tell us what happens abroad to give us some inspiration for France positively? Yes, we see all the different models of responsibility, the population. We really have to find, look and really aim at a territory to see what we need to do for the needs of people. This is a model that has been generalized in Europe. You go to the Netherlands, already functioning like that. You have a catalog, it's functioning like that. In Italy, you have Belgium, Belgium are also, the Swiss are coming, England also, they have a fantastic public system, and they are building it on 42 integrated care systems in a territorial basis. We see the challenge for us is how can we construct our own system? Well, for those that are in the regions, and however, in France, we're very centralized. You could have a territorialized system in a country like France. It's just a question of organization. Constitutional is, should we have a regional or a centralized approach? We have these territorial organizations. We do have the CTPS, we have different departments in France, we have the different territorial units. We have too many layers in France. So what is the right regional level? So maybe 300,000 would be a good level for the territories. And so we need to keep this proximity. That's very important because this gives us the right level of population. So the French regions are too big? Well, it depends. For what? Is that what you're saying? No, for the really large investments in data information system, the regional area is relevant. However, the construction, the local construction of a health program, it's certain in that case that it's not the same thing at Pau as in Bordeaux. So it's this question that you really have to look at. Well, for me, when I was talking about this time issue, UK is well positioned. What UK is doing, they are trying to have this public data system. And so how could we access for this? Be careful with the complexity, because otherwise this is where we really lose this. So that's why the GDPR is very important. So we want to make the UK is organizing Spain in certain regions, also in Catalan, also in 1 year. They now have access in 1 to 3 months. They have access to the data. This is a common ambition, and this is where altogether we can each find the right way to go, and we can really have our priorities and action plan. So I just wanted to complete what you're saying. There's an instrument to exist in France, which is fantastic, which is objective, which is called Caliscope, and it was from the High Health Authority, and you just input information. You can have information concerning all the hospital data, different indicators in the hospitals, even from complications to the prosthesis for the knees, and even then what happens at their home post-treatment. You have all this information. So I invite all of you to look at this. It's a gold mine that can be used. I would like to thank you all.